Hello, I'm Divaka Perera. I'm a consultant cardiologist at Guy's and St Thomas's Hospital in London and a professor of cardiology at King's College London. The original REVIVE trial looked at the hypothesis that PCI would be of benefit compared to medical therapy alone in terms of prognosis, which is to say freedom from death or heart failure hospitalization, and also LV recovery. And overall, what the trial showed was that it doesn't. There is an improvement in LV function in these patients over time, but it's the same in patients who have medical therapy alone or medical therapy plus PCI. And similarly, for the important prognostic outcome of death or heart failure hospitalization, PCI didn't seem to give you any benefit over medical therapy. These patients had a very high event rate, but PCI wasn't the way to improve it. So following that trial, there still remained the question, well, is it related to viability? If we look at the extent of hibernating myocardium, then might we pick a group of patients who'd benefit and from those who wouldn't? But the thinking being that the more hibernating myocardium you have, the more likely you are to do better with revascularization, PCI in our trial, compared to treating you with tablets alone. So that was really the central question. Does viability testing allow you to pick a patient who will benefit from revascularization? But the broader question, even beyond the issue of PCI versus medical therapy alone, is that do these tests allow us to predict prognosis in patients with ischemic cardiomyopathy, regardless of which treatment you give them? And by prognosis, again, I mean death or heart failure hospitalization or LV recovery. So in the population as a whole, is it a useful risk stratifier? And when you come to the question of PCI versus medical therapy, does it allow you to select patients for PCI? To get into the REVIVED trial, we needed to have a minimum threshold of viability. And this was done across all of the 40 recruiting centers in the UK. And they judged their own results and said, yeah, this patient has sufficient viability or not. As part of the viability analysis that we just presented, we actually collected all of the cardiac MRI scans and stress echoes from across the UK and ran it through core lab analysis, so very standardized methodology done by individuals who had no idea who the patients were, what their treatments were, whether they were assigned to PCI or medical therapy, etc. And so that gave us a very robust, centrally adjudicated measure. And through this, we came up with two main types of metric. One is the amount of hibernating myocardium that an individual has. And the other is, and this was only limited to the cardiac MRI cohort, the total volume of scar in the ventricle. And we compared this, looked at the association between these metrics and outcome. First finding, which will surprise many, I think, and will change practice, is that the amount of hibernating myocardium or the total burden of scar has no bearing on whether you benefit from PCI or not. And this is practice that happens week on week in multidisciplinary team meetings around the world. We go, this patient has viability, we should operate on them or give them PCI. This patient doesn't have viability, let's treat them with medical therapy. Our findings say that practice really can't be supported because there is no relationship between the amount of hibernating myocardium or scar and whether they benefit or don't benefit from PCI. So that's the first finding. The second was looking at the cohort as a whole. Is it of value in terms of determining how they're going to do? Hibernating myocardium, that's to say parts of the heart that don't work but are still alive, really doesn't seem to predict whether you're going to survive free of heart failure hospitalization or even whether your left ventricle is going to recover. So it kind of goes right back to core principles and challenges them. We thought viability tests were the prospective equivalents of hibernation. And therefore, if you got it right and you selected your patient right, the LV should recover. That doesn't work. What does work is scar burden. If you quantify the scar burden, that is highly predictive of the risk of your dying, of having a heart failure, hospitalization, and also of recovering or not. The more scar you have, the less likely your ventricle is to recover. Now, that's really significant because at the moment, the amount of scar is not used in clinical algorithms to stratify risk, but maybe it should. And maybe if we use scar, then we might be able to really select out our patients who are going to do badly and focus more advanced therapies on them. I think these findings will have quite widespread clinical application. Firstly, I don't think we can continue to use viability tests like we use them now, because they're not of use in deciding who should have revascularization. And secondly, I think guideline committees may need to consider other factors when triaging these patients or stratifying risk. At the moment, it's all based on LV function. If your LV function is really poor, then you'd be a candidate for ICDs and such like. But I think we need to progress beyond that and perhaps think about SCAR and use SCAR as well. In fact, in our study, SCAR was more predictive of outcome than LV function. So I think practice and guidelines will change quite significantly. And the final change, which is not a clinical change, but an academic one, is our whole concept of hibernation right? Or do we need to revisit the paradigm?